AMA CME credit for physicians and 2 hours of nursing, Virginia Nurses Association CE credit for nurses, nurse practitioners. Uh, Sovah Health is accredited by the Southern States Collaborative, which is a organization that includes the Medical Society of Virginia for accreditation of Category 1 CME programs. The nursing credit comes through the Virginia Nurses Association. The program this evening was designed to promote the desirable physician attributes that include our providing patient-centered care, that we are utilizing evidence-based practice and treatments, and that we are able to work in interdisciplinary professional teams. As far as commercial relationship disclosures, Dr. Reddy reported that he has had the 3 relationships shown here with pharmaceutical companies, and in the sense of participating in their speakers' bureaus. He's agreed to mitigate these by having his slides reviewed for any commercial bias, of which there is none, and also by agreeing to any clinical recommendations will come from evidence-based medicine with fair balance and come from consensus-based guidelines. Ms. Huffman, Ms. Pruitt, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as relationships. This program this evening is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. This fund was established by Dr. Landis, the founder of the Southside Urology Practice or Danville Urologic Practice in its previous names, upon his retirement, and the fund is dedicated to providing speaker support for medical education for healthcare workers in the Dan River region. You will receive this evening or in the morning an electronic emailed program evaluation. We ask you to please take a few minutes and complete that for us. The email will ask you to enter again your name, email address. Please give us your full name, no nicknames or other type of names, in as much as the name you enter there will generate your CME certificate that will come to you electronically. I need to remind everyone that's on the call who is a nurse or nurse practitioner, in order to get your CE credits, you must submit an evaluation form. I'd like to remind our residents who are on the call, and we have quite a few of those, that your residency coordinator tracks your participation as is required by your program for certain CME programs throughout the year, so you do not have to keep up with the CME certificates. Once the evals are received, we will send back to you your CME certificate for everyone on the call. I will point out that for the physicians and non-nurses, our nurse practitioners, an evaluation form is not required to get your certificate, but we certainly hope you will send one in, since it really helps us as we develop and evaluate the effectiveness of the programs we present. For the physicians on the call, please know that we do participate in the Program and Activity Reporting System, or nicknamed PARS, which is a national online database that is managed by the accrediting organization at the American Medical Association. This tracks your participation in the program. In order for you to be reported to that website, you have to one time only, not each year, but one time only forever, give permission to us with your name, birthday, month, and state in which you're licensed. And then once you have completed the program, we will post to PARS your participation. And from PARS and the passport component of that, you can get a list of all the programs you've attended for the past several years. I know that each of our speakers encourages questions. You also can put those in the chat. Mary Kent will be monitoring that throughout the evening. And when they ask for questions, we hope you will engage our speakers, or if you have a comment. We ask you, when you ask a question, once you're finished, please mute your phone so we do not get feedback. You're certainly welcome to do more than one question, more than one comment, and we certainly hope everyone will participate in that process. I'd like to highlight for you a couple of upcoming programs. On November 7th, I'll actually be doing the presentation, which is an effort to review the improving treatment adherence for asymptomatic chronic medical conditions. This was requested through our needs assessment last year for programs this year. Dr. Gunn will be helping me with that program and moderating the session. For the nurse practitioners on the call, let me remind you that there is a Saturday morning, November 16th, nurse practitioner CME activity that will provide nursing CEs. You probably have already received a notice about this. I do know that the leadership of the Southside region of the Virginia Council of Nurse Practitioners hopes that all the nurse practitioners can attend. On Thursday, November 21st in the evening, we will be having a program from our Diversity, Inclusion, and Equity Committee here at Sovah Health. This one will be on culturally competent ways in which to collect sensitive data from individual patients. This speaker we've had before, Pamela Bivens-Pippin, is a nationally recognized expert on DEI topics, and she's done 3 previous terrific programs for us. She'll be assisted by Leslie Sturdivant, who's moderating that program, our market vice president for support and services.
So I went and like rushed and did it.
We need to mute phones, please. So this evening, we're delighted to have 3 speakers. The topics of acute mental health emergencies will be reviewed in sort of 3 dimensions. Dr. Reddy will go first, talking about medical management. Then Mary or Molly Huffman, who is a health law expert, will talk about the Virginia laws directing and managing involuntary hospitalizations. And then finally, Carla Pruitt, who's the crisis services coordinator for the Danville, Pennsylvania County Services Board, will talk about our local resources. Dr. Reddy is a psychiatrist who provides patient care at our Sovah, Martinsville, and Danville campuses. He graduated from medical school at the Osama Medical School in Hyderabad, India, and then completed his psychiatric residencies at the Yale University's Connecticut Valley Hospital. He holds boards in psychiatry and addiction medicine and has a robust professional practice in helping patients with a variety of mental illnesses. So Dr. Reddy, if you want to bring up your slides, I will try to bring mine down or it'll bump me off. And we're delighted to have you do your presentation. Thanks so much. Slides look great. Thanks. I think you're muted, Dr. Reddy.
Okay. Can you all hear me now?
Yes, sir. Thank you so much.
Thank you. Thank you. It's a very big honor for you guys to invite me to talk at this meeting. And I am very excited to participate in it. As Dr. Moore kindly introduced me, I am not just a speaker, but I'm actually I'm working with most of the people in the audience, I think in one capacity or the other, because I do come to see patient care at both Sovah campuses. So having said that, tonight's topic of medical management of acute mental health emergencies, I will start to go through some of this information. Mainly, I will try to define some of these situations and what is an emergency, what is a psychiatric emergency, what are the characteristics of what we call as a psychiatric emergency, and what are the types, and what are the general principles, and what are the specific medical management we can use for best practices. That's going to be my focus today. So having said that, I also will invite the audience, if they have any question, clarification, they can stop me and ask me. If not, I will go through my slides and I will give at the end more time for people to participate in the question and answer part of the session. Okay. So in terms of defining an emergency, I think it's a unforeseen combination of circumstances which calls for an immediate action. And a medical emergency is defined as a medical condition which endangers life and causes great suffering to an individual. So in a way, an emergency is, what it sounds like. We are called upon to keep the situation safe and also diagnose the condition which is causing endangering the person's life. And to go specifically to talk about a psychiatric emergency, usually it involves a disturbance of thought, affect, or psychomotor activity leading to a threat of existence, i.e. suicide, or a threat to people, i.e. Aggression and violence and rageful behavior. And the lot of times these disturbances in thought, affect, psychomotor activity is related to an underlying situation or psychiatric condition, and that's kind of the differential diagnosis we have to look into with our systematic review and understanding the goal of what we are trying to do. The characteristics of a psychiatric emergency is when a situation demands the patient or a relative ask for immediate help, immediate treatment. And usually there is disharmony which you see between the subject and the environment, i.e. something is happening with the patient who is complaining of the discomfort, disharmony. And also a sudden disorganization in a personality which affects the social occupational functioning. Patients come to you with confusion. Patients come to you with various complaints, which sometimes is not very clear, and they are presenting to you in such a way that on further questioning, it is clear that something immediate needs to be done to help them redirect to get them to a safe place. And obviously, the next information is about the objectives: to safeguard patient's life, to decrease the anxiety of the family members who might be involved in that situation, and also give a sense of comfort about the fact that they are in a emotionally secure environment. I think that those are the objectives of the emergency intervention for a psychiatric type of emergency. And if we want to specifically talk about the types of psychiatric emergencies, and these are things which we see almost on a daily basis in our clinical practices: suicide or deliberate self-harm, violence, stupor, panicky emotions, withdrawal symptoms from drug dependence, alcohol or drug overdose, delirium, which could be very much related to multiple medical conditions, epilepsy or status epilepticus, severe depression, which is associated with suicidal, homicidal tendencies, agitation, and stupor, and sometimes as a side effect to the medications which are being prescribed to the patient. And they also can be complications of long-term complications which are manifesting in an acute way for such drugs as isoniazid and steroids, which have a tendency to produce an acute psychiatric type of behavioral disturbance and psychotic thinking as part of the drug use complication. And sometimes people have abnormal responses to stressful situations. And that's also something which we need to get to the bottom of when we have a particular patient complaining or the family complaining of abnormal behavior, which is not usual for the patient. And what are the guidelines we want to generally follow to handle a psychiatric emergency? It is about how you can tactfully, calmly speak to the patient and the family involved, and coordinate the situation and with the people around in such a manner that the anxiety in the room gets down, and also take the command of, if the patient is having an emergency in the hallway, move the patient to the room, as safely, guarding against injury as quickly as possible, i.e., letting the patient into a more safer environment actually decreases the potential for further exacerbating the emergency which is on hand. And if there are other patients or people around the situation, try to get them out of the situation in a routine manner, which would help to help us to deal with the emergency on hand. And sometimes psychiatric emergency is a manifestation of an underlying medical emergency, and that needs to be quickly diagnosed and dealt with. Of course, we are talking about these emergencies happening anywhere, but particularly in an emergency room, those aspects are easily handled. But to keep in mind that sometimes there is a medical cause underlying the behavioral abnormality is important. So we are going to go into very specific psychiatric emergencies now, and the first example of that would be a suicide, deliberate self-harm. I would like to really just present a case as a background in which we can have a discussion about suicide, psychiatric emergency. 25-year-old woman presents to the ED after ingesting a large number of sleeping pills. She expresses a feeling of hopelessness and a desire to end her life. An immediate intervention is required to ensure her safety and provide psychiatric evaluation and support. So that's kind of the background of an overdose patient who has come to your emergency room, and you are on duty and called upon to assess the situation and keep the patient safe and find an appropriate way of treating the patient on an ongoing basis. And it is one of the most common, suicide is one of the most common psychiatric emergency, and it's the common cause of death amongst psychiatric patients. So there is no more of a emergency situation we are called upon to treat other than a suicidal patient. And that is suicide is defined as an intentional taking of one's life. As we saw in that example, she took an overdose of pills. And an attempted suicide, which is different from actual suicide, is an unsuccessful suicidal act with a non-fatal outcome. So that's a very important distinction in a sense that there are people who are expressing their emotions through suicidal behavior, and that is different from a patient with a high risk of suicide who is giving you a lot of warning signs, or maybe even has a history of previous overdose, which needs to be treated appropriately, and those risk factors need to be considered as far as assessing the situation and finding a disposition. From an epidemiological point of view, it's one of the leading cause of death in USA, and the rate of suicide in USA is 14.2 per 100,000 population, and a male to female ratio is 23 versus 5.9, which I think, is some of these numbers are well established, but they do seem to be very impressively consistently there, more in the male versus female. And the highest age group is 75 plus. So I almost see in my practice, 60, 70 and above, with various list of their medical issues and psychosocial issues, which have become harder to deal with in that age group. At least 30 to 50% of the patients are very much at risk of undiagnosed depression, which needs to be appropriately diagnosed and treated. And the most common methods used for suicide are firearm, 55%, suffocation, 25%, and poisoning, overdose at 12%, and other methods, 8%. And what are some of the etiological background for psychiatric disorders as psychiatric emergencies? Major depression, schizophrenia, drug and alcohol abuse, dementia, delirium, and personality disorder. So psychiatric disorders, as we call them, leading to a suicide as a background diagnosis, are these. And the physical disorders are chronic incurable physical disorders like cancer, AIDS, are chronic pain with long-term nature of needing to deal with those types of distresses. Psychosocial factors are marital problems, loss of loved object, isolation, alienation from social groups, financial and occupational difficulties. So these are all very commonly occurring factors which could acutely translate into a decision by the patient to react in a suicidal fashion, which needs to be looked into. And risk factors, what are the risk factors which we need to look into? Our age of more than 40, male gender, as we found out from the ratio, which is high for males, staying single, our recently separated, divorced person would be a more higher risk. Previous suicide attempts do indicate potential for future suicide. And presence of depression, particularly with a lot of guilt, feeling of worthlessness, and there's a higher risk of relapsing once they respond to treatment, because more often than not, they are not continuing the treatment which has gotten them to respond. And also, invariably, what we have seen is that within the first week of their acute treatment and discharge from a hospital setting, they are at a higher risk. So we always recommend that the patient follow with their outpatient team, outpatient provider within 1 week of their treatment, so they have a continuation of their treatment plan, which is consistently managing their depression and suicidal risk.
Dr. Reddy?
Yes.
We have a question in the chat. The question is, does staying single equate to failed relationships or self-isolation? Or
yes, I think the answer to that question is yes. Staying single, if somebody is single by choice because that's the lifestyle they're choosing, that might not be what I am talking about. But I think, if a person is having trouble maintaining relationships, and they are single for that reason, I think, they are, there are a lot of studies which say married couples have a longer lifespan than single people. So that's kind of based on that. My answer is that it's yes,
Okay.
it's a high risk.
Thank you.
Thank you. So the risk factors are when you assess the patient, they have a suicidal preoccupation, they have a background of alcohol and drug dependence. I think in this case, we call it dual diagnosis, where they both have alcohol and drug issues along with clinical depression. And chronic illnesses, which have frequent flare-ups, are even occasional flare-ups, which are severe, can also be a risk factor. Serious loss or major lifeful stressful event. You're talking about probably acute grief situation. Very connected, close family members. And this would be which could be a risk factor. Social isolation. Somebody who doesn't, was a reasonably social person who is not really keeping up with his friends and family. And if people have had a history of high degree of impulsivity in their lifestyle, I think that also is a risk factor. As you see, heeding to the warning signs and mitigating the risk factors and understanding the risk factors and assessing the level of acuity of their suicidal tendencies is going to be sort of the bread and butter of what we do to try to get suicide from not being the part of an ongoing psychiatric condition. What are the warning signs? Appearing depressed or sad most of the time, feeling hopeless, expressing hopelessness, withdrawing from the family and friends, are sleeping too much or too little, making statements like, I can't take it anymore, I wish I were dead, are making covert statements like, it's okay now, everything will be fine, I won't be a problem for much longer. So there are various ways the warning signs come at you, and you needing to have your eyes and ears open to these types of statements, these types of tendencies is going to be important. Losing interest in most activities is also a warning sign of suicide. Giving away prized possessions, making out of will, being preoccupied, talking about death and dying, neglecting one's personal hygiene. These are also some of the warning signs of a suicidal person. There are some misconceptions about suicide, which I think are as important to talk about as the warning signs and risk factors. People who talk about suicide do not complete suicide. I've heard it multiple times, and that's really, I think there's another question here.
Yes,
Yeah,
there
go
is.
ahead.
Okay. It's from Dr. Spillman. Said not to jump ahead, but can you discuss suicide in health professionals, especially in such specialties as anesthesiologists who are in training and residency? It's my understanding that if once an anesthesia resident is discovered to abuse substances, that they have a very high risk of suicide. Thanks.
Okay. I think a lot of what you mentioned there, there is a equal or higher risk in professionals, in certain professions more than the other, and substance use or addiction is an additional risk factor which increases the chances of suicidal tendencies and a successful suicide. So clearly, these are people who are not only have the risk factor, but they also are have the means and have the knowledge, and that would be a somewhat of a dangerous combination. I hope that answers the question. And
yeah, he added, thanks, I'd come across this in a prior setting of an academic medical center.
yes.
Thank you, Dr. Reddy.
Thank you. So the other misconceptions are people who attempt suicide really want to die. I think, when they're attempting suicide, that could be a cry for help and not necessarily um, uh, a wanting to die. And suicide happens sometimes without any warning. I think that's also a common misconception. There are a lot of warning signs. They are missed. That's why we have that misconception. Once people decide to die, there is nothing anybody can do to stop them. That's also a misconception. There is a lot people, if they observe, can do. Acknowledge it and help them divert their attention from their depression, suicidal thoughts, guilt, emotions, etc. And all suicide individuals are mentally ill. Uh, Suicide is an independent issue. It is associated with a lot of mental health diagnoses, but it could also be a independent issue which does need to be diagnosed. I think it's a little bit rarer to do that, but not all suicidal patients are necessarily have a significant mental health diagnosis. Once a person is suicidal, he is suicidal forever. Suicidal behavior is episodic, and it does increase the risk if you have previous suicide attempts or suicidal tendencies for the future, but it doesn't mean that they are suicidal forever. There are people who grow out of it and get into a state where they are not anymore, but they remain at some risk, and that needs to be looked at. And how do you manage? You be very much aware of the warning signs and monitor the patient's safety needs by taking suicide threats seriously and asking about the comorbid substance use issues. And if they are in an emergency room situation and they've made a suicide threat, make sure that they don't have anything dangerous within their reach. And if they are in a home situation, you can advise the parents, patients, family to get the daily medications away, sharp instruments, not in easy reach for them, and remove any ligature type of things, straps and clothing, belts, etc., which could be dangerous in terms of used for in a negative fashion towards self-harm. And also patients, when they are talking suicide, could be in a confined environment with a closed door, and we need to make every attempt to try to talk to them into opening the door, if not even open the door forcibly if need be, if there is a much more of an imminent feeling of danger to the patient. And in an emergency room setting, sedation. In a emergency room setting, a clinician talking with empathy and having them to sign a no suicide contract of some kind, and talking about the positive things in their life as part of the psychiatric therapy intervention. And this is where we call it a psychiatric emergency interview, acute psychiatric emergency interview, where counseling, guidance, helping them understand their feelings, which are including the desire to attempt suicide, and dealing with the ongoing life stressors in a more healthy and a different way than attempting suicide. And of course, if they have a psychiatric condition which is somewhat related to their suicidal tendency, you appropriately diagnose and attempt to educate the patient and provide treatment and give them reassurance that they will feel better with further participation in treatment. The next big symptom. Big issue is the violence and aggressive behavior and homicidal tendencies. I would imagine suicide and homicide. This is the other side of the coin. And in a case example, 40-year-old man comes to the ED highly agitated, shouting and threatening the staff, has a history of bipolar mood disorder, and has not been taking his treatment from the local psychiatric clinic. And in this case, a rapid tranquilization, keeping him in a safe environment and preventing his agitation from affecting him in a harmful way or affecting other people in a harmful way is the goal. Define violence, physical aggression of one person against the other, and there is some irrationality, uncooperativeness, delusional and assaultive behavior on their part. And anybody who has worked in the emergency room in the audience will probably have a clear idea of this. And what are the etiology for aggressive behavior? Organic psychiatric disorders such as delirium, dementia, Wernicke-Korsakoff psychosis, other psychiatric conditions such as schizophrenia, mania, and agitated depression, and withdrawal from drug and alcohol, epilepsy, and acute stress reaction, panic disorder, personality disorders. And again, this is sort of a differential diagnosis you go through, and a lot of times things will be fairly clear on what's going on. And if you do a drug screen and they are positive for a certain drug, which has a tendency to increase agitation, aggression, you clearly will be leaning towards that and addressing treatments based on that. What are the do's and don'ts? Do protect yourselves, unarm the patient, keep the doors open, keep others near you, do restrain if necessary, assert authority, show concern and establish a rapport and assure the patient. And I think, that's, almost like, your body language, your words have to, exude confidence and authority. And I know what I'm doing. I can keep you safe and everybody else safe. I think is what we need to do. And what you don't need to do is keep anything of a potential weapon near the patient, and not sit with your back to the patient. Don't wear a necktie or some sort of jewelry the patient can get a hold of and cause harm to you. And do not keep a angry or provocative family member within earshot, because that could trigger further problems. And do not deal with the patient in a confrontative fashion. I think, I've used the word carefrontation before, and that would actually describe. You have to care, but you also have to assert that you are in control and you are going to use your words, your authority as the physician or the medical professional to keep everybody safe, including the patient. And do not sit right next to the patient or near the patient. You maintain a healthy distance. In managing the patient, if the patient is already tied, and that's what when the agitation is happening, once you get a sense that you have taken charge of the situation, and if you feel comfortable, you can order the patient to be untied, and reassure the patient by talking softly, firmly, with a kind approach, asking direct and concise questions, and avoiding very concrete yes and no questions, and assisting the patient in defining. Sometimes the patients have a tendency to say things which are not clear. So helping them redefine define what the meaning of what they are saying is going to be an important aspect of managing a violent patient. In terms of managing sedation, the violent patients with sedation, benzodiazepines, antipsychotics, which are sedating, are useful. And collecting the detailed history and exploring the cause is also very helpful, because if somebody is having a paranoid delusion and that's the cause of their aggression, if you are in those cases, the sedation aspect of their treatment would be with an antipsychotic, which would have a much higher chance of decreasing the agitation. And carrying a physical examination, i.e., auscultating and doing other things, taking their blood pressure, etc., and having a grasp on their physical condition, and making sure that that's not what is causing the aggression. Checking the hydration status, and having no sharper instruments and not too many furniture in the surrounding. Keeping the environmental stimuli to a minimum, reducing the patient's anxiety, as I have mentioned, by doing an acute psychiatric interview, redirecting the physical outlets, letting them walk around the room, and if there is a possibility of outdoor activity, which could help get some of their energy out, that could also be used to help. Encouraging the patient to talk out their aggressive emotions rather than acting on them, and using physical restraints as a last resort, and doing the restraints in a humane way, and taking a written consent of the caregivers if that comes to that, and getting a second opinion from a fellow professional in that situation also is a useful tactic to prevent any future complications. And try to have a show of force, as they call it, a 4-member team to be present when a restraint is unavoidable as you are going through these decision making. And when you are using restraints, you have to make sure that their circulation is good and there is not a too tight of a restraint, and they are not having any other physical discomfort other than being the 4 extremities being strapped, and their nutritional elimination needs have also need to be managed. How do you protect yourselves? I think, have people with you when you see the patient, maintain a comfortable distance, be prepared to move, maintain a clear exit route before you start seeing the patient and start doing the intervention. Be assured the patient has no weapons. If a patient has a sharp object within their fighting and near range, I think, please have them be put down. I think that would be the first thing which you try to do. Keep something like a pillow, mattress, a blanket between you and the weapon as you are trying to talk and do intervention with the patient. And if you can, distract the patient and get the weapon away, such as throwing water on the face or giving prescribed antipsychotics as a chemical restraint, would be a reasonable thing to keep in mind. So the next aspect of a psychiatric emergency is acute psychotic patient. 35-year-old man brought by the police, found wandering in the streets, talking to self, exhibiting paranoid behavior, believes that people are out to harm him, and is experiencing clearly auditory hallucinations. And he does need a psychiatric emergent treatment for stabilization. I think, the acute psychosis is defined as loss of contact with reality, and their ability to have the wrong perception of what's going on around them. That's kind of the definition of acute psychosis and henceforth paranoia. And if they are talking about having hallucinations and clearly defined delusions, and they are incoherent and disorganized in their behavior and speech pattern, or any combination thereof, I think you can define it as acute psychosis. And etiologically, acute psychosis could be of three different tiers: psychiatrically driven acute psychosis, where diagnosis of schizophrenia, bipolar, schizoaffective, schizophreniform disorder, postpartum psychosis, these are all examples of the psychiatric diagnosis for acute psychosis. Medically, that's the second tier rather. Delirium, hypoxia, excessive high or low blood sugars, systemic lupus, Lewy body dementia, Wilson's disease, sepsis, UTI, Cushing's disease, hyperthyroidism, metabolic and electrolyte derangements are some of the examples of the medical etiology for acute psychosis. And the third tier is the drug-induced recreational drug use of cocaine, alcohol, amphetamine, LSD, PCP, are iatrogenic, such as too much anticholinergic burden, antiarrhythmic drugs, and steroids triggering a acute psychotic reaction to that. Drug withdrawal from alcohol and benzodiazepine can also cause acute psychosis along with aggressive behavior. How do you manage acute psychosis? If it's possible after your intervention, untie the patient, reassure the patient, establish, assert authority that things are going to be safe for the patient and others, and try to follow the general guidelines of a good acute psychiatric emergency interview technique. And behavior de-escalation, I think is a term we use to help patients calm down by offering them comfort, offering them respect, and helping them, giving them clear, concise instructions on what they can and cannot do, and offering them medications which can calm them down. And if you give them an antipsychotic and they only are partially controlled with their psychosis, you certainly can use benzodiazepines on top of an antipsychotic if need be. Some of the examples of medications include a sublingual dosing of olanzapine or risperidone or oral Haldol. And if a particular patient is unwilling to take the PO or sublingual medicine, consider the injectable medications such as olanzapine or Haldol, or even a benzodiazepine such as Ativan, which we use quite often in the emergency room setting. Once the patient is stabilized on pharmacotherapy, it's really an amazing transition for 95% of the patients, that they usually are much more rational once the effect of the medication is done and the patients are calmer and your interventions are beginning to take effect. They are much more amenable to a comprehensive psychosocial intervention, which could really get them away from their dangerous situation. And managing and collecting a detailed history at that point, and exploring the etiology, completing a good physical examination, and if there is dehydration, IV fluids, and keeping the environmental stimuli, and also giving them a opportunity to say that if there is a repeat medication which needs to be done within an hour or two of their behavior pattern happening, but improving, but also escalating back again. I think, being reasonably consistent with medication follow-ups would be reasonable to plan. Again, physical restraints for acute psychosis is a thing which we do quite often, and second opinion and humane physical restraint. The next syndrome, guys, is stupor catatonia. Stupor is defined as a syndrome of akinesis and mutism, but with a relative preservation of conscious awareness. Basically sort of a different form of catatonia, and they have either excitement or withdrawn behavior. They are negativistic, mute, echolalic, cataplexy, stereotypic behavior, garbled speech pattern, excitement, impulsiveness. These are all aspects of catatonic stupor syndrome. And for a patient with stupor, ensure the patient airways are good, because we're talking about a lot of medical etiology where patent airways is important. Maintain hydration, check vital signs for any worsening of any of their medical status, complete a physical examination, do blood work to start investigating and furthering the treatment in terms of understanding the etiology. Specific cause, when it is known, treatment could be more specific. And if the patient is unconscious, you make sure that the skin care, nutrition, elimination, personal hygiene is addressed, and ventilatory support is provided. Panic attacks is another form of psychiatric emergency, and when it happens as part of a psychiatric diagnosis, manifesting through palpitations, excessive sweating, tremors, feelings of feeling choked, chest pain, nausea, abdominal distress, fear of dying, paresthesia, hot flashes. These are some of the symptoms of panic attack. Reassuring the patient in terms of managing panic attacks, searching for a cause, using an injectable diazepam or lorazepam as a immediate intervention to decrease and decompress the panicky emotions, counseling the patient and the relatives around them that there are various causes for panicky emotions. It doesn't have to be a heart attack, etc. It needs to be talked about. Using behavioral modifications, deep breathing, etc. And the last segment I will talk about today is people who have survived a sudden, unexpected, overwhelming, stressful, disastrous situation. And a lot of times, this set of people will have a lot of anger, frustration, guilt, numbness, confusion, flashbacks, and depression. And when such people are, you're called upon to help such group of people, you try to do a very attentive listening. Do not interrupt what they are saying to you. Acknowledge that you understand their pain and distress. Look into their eyes and don't be distracted by doing other things around you. Console them by patting on the shoulder, touching or holding their hand. And using silence. Sometimes silence makes people very uncomfortable. But if a patient is trying to form words and there is some amount of silence, don't feel uncomfortable with it. Give time for the patient. Do not ask person directly to stop crying, because that doesn't help them to express their emotions. And provide accurate information. What happened to somebody else. I think say if you know, say it. If you don't know, don't reassure. Don't give them inaccurate information. And on an ongoing basis, the back end of it, people who are in groups can have group therapy. Benzodiazepines can be used to reduce their anxiety. Referring to a mental health service is important. Educating them on available resources to deal with these, situations which have happened, which is what they're coming to, disastrous situation they are coming to ask help with you. And I think, teaching them coping strategies and helping them understand how to avoid a further progression of the crisis is going to be an important aspect of managing disasters. So thank you very much. I think there's a lot of basic information, definitions, etc. But these are things which are very important to keep in mind and address on a consistent basis. Thank you for attention.
Thanks, Dr. Reddy. We've had an active chat, which we really appreciate. Are there a few questions for Dr. Reddy before we move on to Ms. Huffman? Dr. Reddy, I assume that post-traumatic stress syndrome falls into your last category about disasters. That's unfortunately not an uncommon problem, particularly in veterans, military veterans, and in more recently, the huge number of people that have been devastated by the hurricanes. But I
Yes.
assume all those would come into that category, if that's correct.
Yes, sir. I think, that is correct. Post-traumatic stress, sort of a combination of panic disorder, panic symptom de-escalation, along with the post-trauma response, i.e. reassurance, redirection, resources, helping them express and ventilate, and as such. And then finding a veteran and appropriate resource within their community is a lot of times and more help than what the veteran has been able to accomplish by their own efforts. And I think that that usually works very well.
Thanks. Any other questions, comments? Okay, Dr. Reddy's been kind enough. He's going to stay on the session for our other two speakers. So if you have anything coming up, we'll reopen the questions at the end of the program again for him. Our next speaker is Mrs. Mary, or better known to her friends and colleagues as Molly Huffman. She is a health law expert, attorney who practices from her offices in Richmond. She began her education at the University of Virginia, where her undergraduate degrees were in English and history, followed by the University of Richmond School of Law, where she had the distinct honor of serving as Chief Justice of their honor court. That's a tremendous accolade for anyone in law school. She also received the Lewis F. Powell Medallion for Excellence in Advocacy in school. She is a member or has been admitted to the bar and practices her skills in health law in Virginia, West Virginia, Tennessee, and North Carolina. She's a member of the Virginia Bar Association's Health Law Section, which means she participates in developing health laws, interpreting them throughout our Commonwealth. And she was recognized many times by many groups, but one notable one is the Virginia Business Magazine considers her a member of the legal elite. She has been a long-standing advocate and consultant for Sovah Health, and before that, Denver Regional Medical Center. She's going to talk about basically the Virginia or Commonwealth's laws regarding retaining patients in care when they may not be so happy to stay with us. So, Ms. Huffman, thank you so much.
Thank you, Dr. Moore. I really appreciate that. Can you all hear me okay?
We can.
Okay,
Yes.
Thank you. Really appreciate the opportunity to be with you all this evening. And I'm going to start with ECOs, TDOs, and commitment orders in Virginia. For any of you that may have practiced in this area, it has changed a decent amount in the last handful of years. So I will start in, and if you have questions, please feel free to put them in the chat. I definitely want to make sure that I touch upon what might be most relevant for you all. Obviously, this is for informational purposes. If you have specific legal questions, obviously take those to your legal counsel, and they're happy to help you with those. So when we have a patient who's in a psychiatric emergency, can we hold them? And typically the answer is no, we cannot unless we have a vehicle to do that. And so there are basically 3 ways in Virginia to do that. There's an ECO, which stands for Emergency Custody Order, a TDO, a Temporary Detention Order, or an involuntary commitment, which is a much longer period of time. And we're going to go through each of those tonight. If you have a patient, usually it's in the emergency department, who's in a psychiatric emergency, and we do not have a hold of any kind, and they choose to leave, it is always our recommendation that you contact law enforcement and have them hopefully help us with the patient when they leave the property. And then lastly, considering the duty to warn. So let's say we have a patient who says, I'm going to leave here and I'm going to hurt myself, somebody else, a neighbor, a family member. As a practitioner in Virginia, you would have a quote duty to warn. And that can be hard because you can't hold that patient, but you've got to be able to warn. And again, we go back to calling law enforcement as they leave. So the next slide, when may a hospital hold a patient absent his or her consent? We talked about the 3 kinds of orders, and I'm going to go through those in much more detail. So we have the ECO, the TDO, the commitment order. The other vehicle that you have is an advance directive. But, and here's the kicker in Virginia, just because a patient has completed and endorsed an advance directive does not mean that we can hold them over their objection. There is a specific portion of the approved advance directive in Virginia that says, hey, I may know that I'm going to have a psychiatric or behavioral health emergency. Maybe it's somebody who's experienced that, excuse me, for some period in the past. And they can complete that portion of Virginia's advance directive that says, I'm appointing somebody to make that decision to hold me, even if I'm objecting in a psychiatric emergency in a behavioral health setting. But every advance directive does not have that. And having done this for almost 22 years, I can tell you it's often not filled out. And that provision was not available until the last handful of years. But even then, it's oftentimes not filled out. So if somebody hands you an advance directive and says, hey, I can make this decision, my best advice is just be really sure you're carefully reading that advance directive to know if we can listen to that loved one, that family member, that guardian, as to whether we can hold that patient over their objection. If that portion's not filled out, then we're back to that ECO, TDO, commitment order option. And at the very end of this presentation, I'm going to talk about medications over objection, because the ECO, TDO, and commitment order do not give us the ability to do psychiatric medications over objection in and of themselves. There often has to be a separate judicial authorization for psychiatric medications over objection, and we'll get to that as well. So I'm quickly now going to transition and talk to you about EMTALA. And you may be thinking, why are we talking about EMTALA? This is Virginia's behavioral health psychiatric laws. But, and here's the kicker, EMTALA is often triggered in these situations. And EMTALA, being a federal law, kind of trumps or oversees, if you will, Virginia's law or laws on this. So when is EMTALA or triggered, if you will? Anytime somebody presents to one of our dedicated emergency departments, or anytime they set foot on our property. So they could be in an ambulance out in the parking lot and EMTALA is triggered. They could be in an air ambulance on our property. However the case may be, if they are on our hospital property, then EMTALA has been triggered. And I said that if they are presenting to a dedicated emergency department. What is a dedicated emergency department? You'll see on this slide what that definition is. If it's licensed by the state. So think of your regular emergency department. But it can also be L&D, an urgent care clinic, or a psych unit. Why is this important? Because once somebody comes to what is defined as a dedicated emergency department, even with law enforcement or a member of the CSB, that individual becomes a hospital patient and all of our EMTALA obligations are triggered. And that's going to be really important. Again, having done this for a long time, I can tell you it's not uncommon to see hospitals say, oh, well, CSB's got that, or CSB's evaluating that. If they're on our property and they're one of our dedicated emergency departments, all of the hospital's EMTALA obligations are triggered. They're our patient, and the CSB can't do that because the CSB representatives are not on our medical staff. And it's not uncommon to see folks say, well, we're going to delegate that to the CSB, and that we really can't because our federal obligations are bigger than that. And we have that really on ourselves. So these next two slides I'm going to transition to now are EMTALA myths. And I italicized and underlined that because I want you all to be aware that these two slides, there's 4 bullet points on each, are myths. Each and every one of them is incorrect in some way. So we'll go through them. CSBs are responsible for conducting the psychiatric portion of the medical screening exam. Again, if you're in the EMTALA mindset, MSE, medical screening exam, it's a term you would all know. If somebody comes to an ED, we have to screen them. Do they have a biological healthcare issue or a psychiatric healthcare issue? And there are 2 components to that, the organic medical piece and the behavioral health psychiatric piece, 2 totally separate portions of that MSE. And we cannot delegate the psychiatric piece to the CSB. Sure, the CSB is going to come in and they're going to do their TDO evaluation or assessment, but that is going to be separate and apart. We as the ED staff still have to do our own behavioral health screening. So next myth, state psychiatric hospitals cannot accept an otherwise medically stable patient who is receiving ongoing treatment such as dialysis. Also a myth. Sometimes state facilities will tell you, oh, we can't take that patient, they've got underlying medical issues. That is not true. Oftentimes they want to know that we've screened them, if you will, or given an affirmation of our medical screening exam, but they can still take the patient. Third myth, if no private facility is willing or able to accept a patient pending a TDO request and the ECO expires, the patient must be discharged. Not true. The state psychiatric facilities, a handful of years ago, the state law was amended to say they have to take our patients. And many of you being in these waters probably have found that when COVID hit, the state psychiatric facilities said, hey, we can't take those patients. And this backstop was put in before COVID started, a few years right before COVID, saying we have too many patients in hospitals where the ECO expires, the hospitals can't hold the patient and they're walking. So we're going to put this backstop in that says a state behavioral health facility has to take the patient. And so that is supposed to still be the case. It is still the law. And we'll talk a little bit more about that. But we really should never let a patient just walk because the ECO expires. We need to either call the psychiatric facility, the state psychiatric facility, or move post haste with the TDO to get that enacted with the court. We'll talk a little bit about those timeframes coming up. Okay, fourth myth. In the scenario above, the hospital and the ED physician are protected from EMTALA liability because of state commitment laws. Not true, because the EMTALA laws are federal. They trump, if you will, they're above the state laws. And many years ago, CMS let us know here in Virginia, hey, we don't really totally love your state psychiatric laws. And we're always going to make sure that the federal ones are kind of over that. So we've got to make sure, I guess my message to you all is, let's just be sure we don't get too comfortable with our state laws, because we always have to be accountable for the federal EMTALA laws, which are more stringent in this situation, and don't let us delegate entirely to the CSBs or to anybody else. Okay, turning to our next slide on 4 more myths about psychiatric patients. Once a patient is determined to have an emergency medical condition, or an EMC, of a psychiatric nature, the CSB should be called for a TDO assessment. Part true, if we're going to get a TDO, they do need to do a TDO assessment. And if you think of a big pie or a piece of pizza and you think of one slice out of that, the CSB is doing the TDO assessment. But that does not circumvent our emergency medical screening responsibilities or any of our other hospital obligations, because that is our patient in the hospital. So once we know they have an emergency medical condition, the real answer is we need to do our full emergency medical screening exam, both biological and psychiatric, and also call the CSB to do their TDO evaluation. All right, we're down to 3 more myths. All TDO patients must be transferred by law enforcement in a squad car. That also changed a handful of years ago, and there are now many more alternative transport options, and we'll talk about those on a slide further along in the presentation. A magistrate considering the appropriateness of a TDO for a behavioral health patient will not take into account the medical judgment of the attending physician. Also false. Those of you who are physicians or any of you working with physicians, I cannot emphasize enough how important it is for the physicians to share their medical opinion of whether this patient should have a TDO or not. I think a lot of times folks think, oh, others have spoken, the family has spoken, CSB has spoken, whoever else. The physician who has gone to medical school and is an MD or a DO in the Commonwealth of Virginia really holds a lot of weight there. And I just don't ever want folks to think that they should not provide that testimony, both for their own protection with their license and the hospital. So if you disagree with whoever else is testifying, you should always provide your own input in those hearings to the magistrate or the special justice. And lastly, if a patient is subject to a TDO, the ED or attending physician is no longer able to weigh in on where the patient will be transferred and how the patient will be transported. Also false. So our Virginia statute says that the CSB will figure out where this patient is going and the mode of transport. But even though our Virginia statute says that, it's completely in opposition to the federal EMTALA obligation that says it's our patient. The hospital has to determine where that patient's going under the conditions of participation. We have to figure out how to safely get them there. So my best advice to folks is, hey, we've got a federal law and a state law that don't totally mesh. So what we can do is certainly partner with the CSB, and any help they can give us to find a good bed and a good mode of transport is fantastic. But what we can't do is totally hand off that obligation to the CSB. We need to still stay in contact. We need to feel comfortable with that. And just like with the conversations with the judge, if we don't agree with it, the hospital should always feel empowered to say, we've got to have a say in this. And either we do or don't think that that's the best mode of transport for this patient. Okay, so that takes care of our EMTALA overlay, if you will, and we're now going to turn to the state laws. So ECO, that stands for Emergency Custody Order. Think here of a patient who is in dire distress. We need help immediately. It is very, very short. The ECO in Virginia is no more than 8 hours. There is no longer an extension available. Any of you who might have been swimming in these waters for a while, you may remember a handful or more of years ago, we had 6 hours and a couple of hours extension. They just pushed them all together and said, you've got 1 8-hour block. There's no opportunity for an extension. And that person, once the ECO is issued by the court, stays in custody with law enforcement, either until the TDO is issued, the person is released, maybe they're doing better much more quickly than anticipated, or the ECO expires. That's it. Once that court has issued the ECO, it has to be executed and moved on within the 8 hours. So it can last 8 hours, but it also has to be moved on with that 8 hours. Let's say law enforcement or whoever's going to execute it gets held up and 8 hours and 15 minutes go by. It is no longer valid. After that 8 hours, it is null and void and has to be started over. Any magistrate shall issue an ECO when he has probable cause to believe that any person has a mental illness and there exists, this is the key word, a substantial likelihood that as a result of the mental illness, the person will in the near future, and you can read those bullet points, it's basically cause serious harm to himself or others, is in need of hospitalization, and is unwilling to volunteer to do that. So this is somebody who's saying, I'm not going to get help. I'm not going to be hospitalized for this. So somebody who is combative or pushing back on this, and there has to be information or belief that he is going to cause harm. So what is the probable cause piece? And this is where the judge can take any of this into account. There can be a petition, a written petition. The judge can take into account the recommendations of the treating physician, immediate past actions. That's usually a family member saying, hey, today and yesterday, here's the behaviors we've seen that have been frightening, that have been concerning. Past mental history, relevant hearsay evidence. So in a court of law, you wouldn't, hearsay is what somebody else heard or said. And you can read the other bullet points. It is very, very broad with the idea that they want the court to be able to take into account any information that may help get this person the help that they need. And these bullet points are the same ones for the TDO, which is the next section we'll get to. But it gives you an idea of how broad and how vast the bucket of information is that the judge, the magistrate, the special justice may take into account when deciding if there needs to be an ECO. So once that ECO is issued, that person is taken into custody and transported to a convenient location to be examined and to decide if the next step, which is the TDO, should happen. The evaluation that is done is by a CSB member. And it's not just any CSB member, it's somebody who's skilled in the diagnosis and treatment of mental illness, and they have to have completed the certification program. So they'll come then do the evaluation or do it by two-way video monitoring. That's also acceptable under the code. The ECO is also supposed to talk about the primary law enforcement agency. So is it your county police? Is it the sheriff? Who is taking that person and transporting them for purposes of this ECO? For the ECO and the TDO, the court can say, we're going to authorize alternative transportation, a family member, a representative of the CSB, or somebody else who is trained in how to transport such individuals. I will tell you that was not always the case, and many of you may remember in Virginia when that was not the case. And there were quite a number of cases where there were detrimental and bad outcomes. And so they expanded the list of people who can transport those folks. Since that has passed and changed, we have, as you can imagine, likewise seen a handful of bad outcomes too, when somebody other than law enforcement was transporting that person. So just a lot to take into account, and the courts don't always get that right. They don't always have the right bucket of information in front of them. But I think the point I want you all to know is that you do have that at your disposal. And if an ECO is requested, if time is of the essence, it does not have to be law enforcement that is transporting that individual. So again, we transport to the hospital or other medical facility named in the ECO. And the point of that is to get a medical evaluation prior to admission to the hospital or the TDO. I'll quickly go over this one because this is just a bit more about what that transport looks like. Okay, coming in 2026, this next slide I want you to know about because it was passed in this past winter's General Assembly. And it was based on a case here in Virginia where a gentleman was having a psychiatric emergency running down an interstate, unclad, was taken to a psychiatric facility. He ended up passing away. There was a hold situation, but the long and the short of it is the family was very upset that they were not present for his evaluation, and they felt that they could have provided some much needed information as that psychiatric emergency was unfolding. So Virginia's General Assembly last winter said, we are going to change the ECO law to add this provision that says a family member has the right to be present during the evaluation of that person. What is their psychiatric emergency? What is going to be recommended? And you will see it says the evaluator conducting the evaluation or the hospital emergency department and treating physician. So those are the categories. Shall allow a family member to be present unless it is going to cause harm to the patient or others present, a medical, clinical, or safety risk. And I put ... because I really had too much on this slide, but the reality is the statute goes on to say that this additional provision should not delay medical care. So while the General Assembly wants us to give these individuals the opportunity to have a loved one present, if it will help us get information, we should not delay. So it's not a situation where we say, oh, Aunt Susie can't be here for 30 minutes, so we're not going to do the evaluation. No, we still need to do the evaluation, but if the person has a loved one that can be here post haste, then they can be present unless it's going to cause a safety concern. That provision I mentioned was passed this past winter. It is not going into effect until 2026. And they've asked for some additional kind of thoughts and parameters around this in this coming winter 2025 General Assembly. So kind of more to come on that piece. The last thing I'm going to say on ECOs before we move on to TDOs is this idea of a paperless ECO. And you may have heard this term before. I've talked a lot about getting an ECO for 8 hours from the court that allows us to examine this patient. The reality of this is law enforcement has carte blanche ability to issue an ECO without ever calling the court or a judge. So, as an example, we have a police officer driving down a street in the middle of the night and they see an individual on the side of the road in a behavioral health crisis or emergency. That law enforcement officer can stop on the side of the road and take that individual and transport them to your hospital or any other hospital for evaluation under same thing as a court order, an ECO, but it's called paperless. And here in Virginia, our lawmakers said, you know what? Sometimes, because this is such a short window, we're talking 8 hours, sometimes getting a judge on the phone in the middle of the night, what have you, may not be the best way. So we are going to essentially tap our law enforcement officers in Virginia to kind of be a judge. And they can do that of their own will, their own accord. And that's important for emergency rooms and emergency departments to understand, because a police officer may bring somebody to you in the middle of the night and say, hey, I've got this person under an ECO, I need an evaluation, but may have no paperwork to show you because they've done this by the paperless route of their own accord. Okay, so we're done with ECOs, that 8 hour, really short time frame. We're going to move on now to our middle bucket, which is the temporary detention order, or TDO by abbreviation. Same standard as the ECO that we just went over. It's a little bit longer. So the ECO we said had to be served within 8 hours. It only lasts 8 hours. Here, it has to be served within 24 hours and it lasts for 72 hours. So we've got a little bit longer. We're dealing with 3 days here. The idea is that they want to give everybody the time they need to examine the patient, the pre-admission screening report, and initiation of mental health treatment to stabilize. And again, 3 days may seem long, but the hope is that we do not have to involuntarily commit this person. And we'll get to that one next. That's 30 to 120 days. But the idea with this 3-day TDO is, might we be able to give some emergency behavioral health treatment to this patient such that even if they don't get to baseline, maybe they regain capacity and say, you know what, I am willing to be admitted voluntarily. I will agree to treatment. So it gives us 3 days to try and provide a better scenario or a better picture. It also gives us those days for our emergency room folks to fully examine this patient, and for the patient to have a bed where they need to be, as well as for the CSB to do their pre-admission screening report. So everybody gets a little bit more time with the TDO order. Let's say the TDO lapses. So subsequent orders may be issued upon the original petition, that original TDO petition, within 96 hours after the first petition is filed. However, a magistrate must again obtain the advice or of an employee or a designee of the CSB prior to issuing a subsequent order upon the original petition. So that CSB involvement, having our CSB evaluator do an assessment of this patient, is going to be critical each step of this TDO process, whether we're dealing with the original one or a subsequent request. So let's say we didn't have that original ECO, that 8 hour, I call it a Band-Aid. It really is just this short window to get somebody help. Let's say somebody comes in without that ECO. That's okay. We don't have to do the ECO, the TDO, and then the commitment. You can skip that 8 hour ECO if the circumstances necessitate. So the judge or the magistrate can issue a TDO without the ECO. And a magistrate may issue a TDO without a prior evaluation if one of two things. The person was examined within the last 72 hours by the CSB, so really quickly before that they had been evaluated, or there is a significant physical, psychological, or medical risk to the person or to others associated with conducting such evaluation. That one's not used a ton, but imagine the person is so volatile that the CSB and the ED staff might be at risk of doing this evaluation. And it is apparent to everybody involved that this person absolutely has to have a TDO. The magistrate will have to hear evidence of that. But if so, those are the two ways that he can forego a prior evaluation and go ahead and just issue that 72-hour TDO. So the 72-hour TDO, they need to be in a behavioral health bed, a facility bed. And the CSB is going to help us with that too. Now, I say help. I keep going back to we cannot delegate our responsibilities to them, but they can be a partner with us. And they can help us find a TDO bed. And that TDO bed or placement is supposed to be identified on their pre-admission screening report and needs to be approved by the magistrate in their order, saying, instead of leaving it blank, which is also something that I've seen happen across the Commonwealth, it can't just be fill in the blank. The magistrate, when they issue the order, is supposed to say, okay, John Smith is being issued this TDO to go to bed X at facility Y, and this is how they're going to get there. All of that should be in the TDO order, and then they will go to that bed for 72 hours, up to 72 hours. That person needs to remain in the custody of law enforcement until custody has been accepted by the facility identified in the TDO. So the TDO says, go to facility X. Law enforcement takes them to facility X and might need to still stay with them unless facility X has the ability to take safe care and control. And usually there is an MOU, a memorandum of understanding, that has been put in place in advance to say that they are able to provide that safety and security and take that off the hands of law enforcement. If not, then law enforcement needs to stay until that is figured out. These next couple of slides just kind of parse down a level more, if you will, what the CSB's role is. So I mentioned they're going to do that TDO evaluation. They're going to work with us as a partner to decide the appropriate mode of transport. And they're going to evaluate the patient if the patient's unwilling to consent. Once the patient says, hey, I get it, I need some help, I'm willing to voluntarily be admitted, then this process kind of gets pushed to the side until they object again, or if they object again, and they can be voluntarily admitted. I'm going to skip through this really quickly in the interest of time. Okay, this next one a little bit ties back to how we started the presentation with the EMTALA concerns that overlays all of this process. And I just reiterate that if your ED physician disagrees with the CSB on whether a TDO is needed or the placement, they should always let the magistrate, the special justice, know of their objection. Because really and truly that liability is going to rest with the hospital and the physician, not with the CSB. And so the physicians are the ones who have gone to medical school and really know if there's going to be a psychiatric crisis at hand. And so we just really recommend that if they are at all at odds with or not fully in lockstep with anybody else that's part of that hearing, a family member, a CSB representative, anybody, that they let the court know that. One more new addition for you all, for any of you who may have been comfortable with the process in the past. This was some new legislation that was also passed in 2024. It will be effective July 1st, 2025. And JLARC did a study. We also had a committee in Virginia that looked at this. And it said that symptoms or behaviors that manifest from a neurocognitive or neurodevelopmental disability are not sufficient in and of themselves to justify a mental illness. And it allows the state hospital to reevaluate the individual's eligibility for a TDO and to refuse that admission if it meets that criteria. So what this basically says is folks who have these neurocognitive or neurodevelopmental disabilities were a little bit too frequently being sent to these state hospitals with folks saying they're having a behavioral health emergency. And the state hospitals were pushing back some on that. And so they're carving that population out and saying that kind of fail-safe I mentioned, where the state hospitals have to take a patient in crisis, it carves this population out to say that in and of itself, that they have this disability is not sufficient to equate to a mental illness. and the state hospitals can hit the pause button and ask for more information and more assessment before they have to take such a patient under the TDO kind of fail-safe statute, if you will. I'm going to go quickly in the interest of time over transports. Really just encouraging folks to, if you are a member of the hospital team evaluating a patient, my point here is really just to say, if you have thoughts on the transport, to voice them. One of the examples I can give is we talked about it used to have to be law enforcement, and now it can be a family member or somebody else. A situation where a young man, a teenager, was being transported by family, and he asked the family to stop at home to get some clothing, and the mom was making him a sandwich in the kitchen, and he ran upstairs to get the clothing, and committed suicide. And so I give you that as an example that nobody expected that, and they thought the alternative transport in that order was going to be safe, and it was not. So there's a reason for the alternative transport, which is to make things more comfortable for folks in a crisis, to make things more expedient and not always have to rely on law enforcement. But I just really reiterate to the care team that if you have a concern with an alternative transport mode being included in an order, just like with the other pieces, just make sure to speak up and let the judge know that in the hearing, so that at least that's on record as to your concern if you have one. Not to say there's a concern in every situation by any means. Okay, I think we've touched on that. So if we cannot find a bed for this individual, this goes back to the notification to the state hospital. It's really important to let the state hospitals know early that that may be the case. And the CSB is a partner with us in doing that as well. We've touched on this, but if there is a disagreement, just be sure that anybody on the care team at the hospital is letting both the CSB and the court know that in the hearing as to what that concern may be. So we've gone over ECOs, 8 hours. We've gone over TDOs, 72 hours. We are now to our final step in this process, which is the commitment hearings and commitment orders. And these are held within 72 hours of the execution of the TDO. So we mentioned the TDO can last for 72 hours. That commitment hearing has to happen within those 72 hours. The only exception is if the end of the 72 hours hits on a weekend or a recognized holiday, Christmas, New Year's, so on and so forth. Then you can bump it to that next day. Otherwise, it is the hard and fast 72 hours. And when the judge is conducting the commitment hearing, they have to do a couple of things. They have to provide an opportunity for that individual to have legal counsel, either appointed or chosen. And at the beginning of that hearing, the judge has to say, do you voluntarily agree to admission? If the person says, absolutely, I will get inpatient treatment voluntarily, then the whole commitment hearing is null and void. When the General Assembly passed these laws, they wanted it to be as agreeable and as non-confrontational to patients as possible. And if at any point in this process, a patient will voluntarily agree to the treatment, then there is no court order. That's not to say that the care team may not have to, on a dime, pivot and request an ECO or a TDO again if that patient changes their mind. But that is kind of the process. The court has to hear the same information, that same pre-admission screening report, any other relevant information from physicians, from family members, from anybody else who may have a say in this. And then the judge or the special justice enters an order if the patient will not agree and the criteria is met for a period, and this is key, not to exceed 30 days from the date of the order. That first order can only be for up to 30 days. And if at any point in those 30 days, the treating physician feels that the patient has regained capacity and is better and well enough such that a committed order is not appropriate, they are required to let the court know that and essentially negate that order, rip it up, if you will, early, if that patient gets better in advance. Otherwise, it's up to 30 days. Let's say we go through our 30 days and that patient is still not well enough in the physician's eyes to leave and will not agree to be voluntary. Then you go back to that special justice or the judge and you request a second order. And this second one can be much longer, up to 180 days. So we're talking a long time here. But the 180-day mark is really our cap, our final for a commitment order in Virginia. So last point to make is a judicial authorization of treatment. So we've talked about these 3 buckets of how to keep people: ECO 8 hours, TDO 72 hours, commitment order 30 days, and then up to 180 days. If you have any of those 3 orders, yes, we can help this patient. We can provide certain treatment, but here's the carve out in Virginia, and this is very interesting. We cannot provide psychiatric medications over their objection. So we have the person in our hospital, they're under an order, and they say, I don't want psychiatric meds. And it also includes ECT. So I don't want psychiatric meds. I don't want ECT. I'm not taking it, whether by injection or orally. Unfortunately, or at least I think unfortunately, those orders that we have don't give us the ability to give that medication. So it is, I say unfortunately, I mean, it definitely has its purpose, but it is one more step for you all, because we have to get a separate judicial authorization of treatment order to give the psychiatric or behavioral health medications over their objection. Now, if they're not objecting while they're under the order, fine, go ahead and admit it. This is only when they are objecting. And we go back to that advance directive I mentioned at the beginning, where a family member could commit somebody against their will if they filled out that specific section of the advance directive. Same with the behavioral health medications over objection. There's a specific section in the Virginia advance directive, and if they fill it out, often it's filled out by somebody who has a long history of mental illness or behavioral health issues, and they will say, I may well be in this situation. If I am admitted to a behavioral health facility and I'm objecting to psychiatric meds, I give fill in the blank, a mother, a sister, a spouse, the ability to consent to that, even if I'm objecting. Now, if that specific section's not filled out, we have to get this. And I will tell you all, I have to get these orders more times than I can tell you. Since COVID, the uptick of the need for judicial authorization of treatment orders or psychiatric meds over objection has increased exponentially. And typically in most jurisdictions, the special justice will hear those at the exact same time they're doing the TDOs and the commitment orders, not the ECOs, but the TDOs and the commitment orders. They will just loop one of these meds over objection orders, and they'll hear testimony from the care provider, and the patient or the patient's representative, and then it's usually fairly quick. But I'll just put a pause there. If any of you have any questions on that, certainly feel free to reach out to Mary or Dr. Moore, and I'm happy to provide any additional insight on those as may be needed. So with that, I'll pause. I know that's a lot of information. It is both a very delineated process, but also a very complex process. So I'll pause if there are questions, and really appreciate y'all's time. Thank you.
Ms. Hubman, thank you so much. Do we have any questions before we hear our last presenter this evening? Let me ask something that may be dumb. As most of the people on the call that know me know, I other than working with our residents, so I've not had a lot of ER direct patient care in a while. I noticed that for the commitment hearing, they had to do it within 72 hours. I assume sometimes that's done by video or Teams as opposed to everyone having to go down to the court. Is that correct?
Yes. So I don't do these directly in the Sovah market, but I do them across other parts of Virginia still. And post-COVID, so I guess I'll preface it by saying this. I don't know exactly what your process is in Danville, but speaking from other parts of the Commonwealth, post-COVID, we're doing all of them virtually. There used to be a room in a behavioral health unit where the special justice came and we did all of these hearings. Post-COVID, we're doing them on a secure link, really for everything. And then an iPad is taken to the patient for presentation to the special justice.
So the clinical team really can participate in this. It's not a barrier. I mean, they can just get in a secure area within the ED or in their ward or wherever and participate. That's great. It really is. Any other questions before we move on to Ms. Pruitt? Mary,
Hey,
anything in the,
sorry.
please? Please.
Yes, I just, from a nursing aspect, I know one question that we often have is if our patients in the emergency department, typically when they're under an ECO, we're accustomed to having officers with them. And then occasionally, if they're from a different county or something, I'm not exactly sure of the reasons why. When it transitions to a TDO, or maybe they're admitted, they need medical treatment, and we have a commitment order. So we've went past the TDO. When the officer leaves, we often have questions surrounding what the hospital obligation is in regards to when that patient, if they were to escalate and then try to leave our facility, being, in our emergency department or inpatient units, we're not a locked unit, and they're escalating. What would the hospital obligation for staff be in those situations?
Are they still under an ECO?
So, it's usually they've been escalated to a TDO or a commitment order.
Okay. So if they are under an order, then you have the ability and really the obligation to keep them there and to keep them safe. And so at that point, I say you transition to the hospital's policies on a restraint, whatever your hospital's policies are on how you might appropriately restrain somebody, including chemical restraints. And that's a whole nother presentation because Joint Commission and everybody's kind of changed their views on that. So all I really tonight can say to you is just make sure you're in line with your hospital's policies on that. But you absolutely can and need to keep both the patient safe and your staff safe, and the patient can't leave, because we really have a court order saying we have to keep them and we have to keep them safe. And we've got to do it within the confines of how we can appropriately restrain patients in today's environment.
Any other quick questions? Well, Ms. Huffman's going to stay on the call also, which we're so grateful. Dr. Reddy's still on the call. There'll be some time a little bit later if something comes up. We're delighted to have our third speaker, Ms. Carla Pruitt. And Ms. Pruitt's the Crisis Service Coordinator for the Danville, Pennsylvania County Community Services Board. Her background began at Lynchburg College, where she received her first degree for interdisciplinary studies, and she has a lot of experience, and her teaching emphasis was in special education. She went on to complete a master's in social work at Radford University, and she is a certified social worker, and now is basically the coordinator for crisis services for our local community services board. So when you talk about those folks that come and assess patients, most of them have been trained by Ms. Pruitt. She supervises a crisis services program. When we've done programs similar to this in the past, we're always asked, well, this is all interesting. What's available in Danville? What's happening here in Danville, Martinsville? So we asked Ms. Pruitt to talk about that so we all can have an awareness of local services and resources. Carla, thank you so much.
Thank you for having me. So I will give a disclaimer that I'm going to provide some information about Martinsville and Piedmont for those of you who are working in that area. However, all CSBs are slightly different in the services we provide. There are some set services that we are state mandated to provide, but sometimes they're done a little differently. So I will do my best to cover what Piedmont does, but for more specifics, if you have specific questions, you would want to reach out to your local CSB partner there. So tonight we're going to talk about just a crisis services overview, and I really want to talk about how crisis services has changed so much over the last several years. So when I started working in crisis 8 years ago, we were basically just emergency services, and that is the piece that's doing the assessments, the obtaining the TDOs, things of that nature. But it has changed so much. Virginia Crisis Services is now a full continuum of services, and these it's in an effort to prevent psychiatric hospitalizations and decrease the number of TDOs. Part of the criteria for hospitalization is that it needs to be the least restrictive level of care. Several years ago, emergency services, we didn't have all these other services to be able to offer, and pretty much we had to feel comfortable with someone going home that day, or they had to go to the hospital. There wasn't a lot of in between, but now there are a lot more wraparound services, and we are working to expand those even more and to also just educate the community about what those services look like. So the first piece is that emergency services piece. Emergency services is state mandated, so it is always going to be around. It is at every CSB in the state, and that is doing those assessments for individuals who are either under the emergency custody order, or they may just be, they may come into us voluntarily and we still conduct that assessment. That assessment determines if TDO criteria is met. We also are the ones who, when it is going to be a TDO, we're doing bed searches. I know for those of you who work in the ER, it may feel like these patients have been here for days sometimes because the system is just a little backed up from what it used to be. And with that, we are doing bed searches every shift in Danville. I don't know how Martinsville does, but I know for our CSB, as long as the person is medically cleared, then we are doing a new bed search pretty much every shift in an effort to get patients moved as quickly as possible. I think Molly mentioned already that with the CSB, we are the ones who are doing those TDO assessments, but it does take a specific certification. So those are clinicians who are mastered level and have gone through a training that is pretty extensive to be able to make those decisions. It takes several months to get them trained in that specific piece so that they are able to provide an adequate assessment. So one of the services that we have now is mobile crisis response. This is for community-based care. It is focusing on meeting the person where they are, coming out to them. And the way this is kind of initiated is through 988. If you have seen the advertisements for 988, you may already be familiar with some of this. For those of you who haven't, 988 is a new number that individuals can call if they're in a mental health crisis. It's basically like 911, but for mental health crisis. So with that, a call center receives the call. They then determine what level of response is needed. There may be situations where, for safety, the appropriate response is law enforcement to go out. But if it's not a safety concern, then they dispatch a mental health provider who is trained specifically in mobile response to go out and provide assessment at the scene for that individual. So these responses are supposed to occur within an hour. Ideally, of course, we live in a very large county. So if we're in Danville and we get a call all the way in Hurt, it could take quite a bit of time to get there. The other piece of it is, for us, we have regional mobile crisis. So we have a team specifically that can go out to calls in Piedmont CSB's catchment area, as well as Southside's CSB's catchment area. So that can expand as far as Mecklenburg all the way to like Franklin County, Martinsville. So sometimes it takes us, we could be on one end of our region and need to go all the way to the other end. So it could take a little longer. I do like to make sure that we note we are contracted to provide that mobile crisis response. However, it's not just CSBs who can provide that response. Private agencies can also have a an agreement with the call center to do that. They also have to go through the same training that we would have to go through to be able to provide that response. But I do like to make that distinction because just because someone calls 988, it doesn't necessarily mean they're getting a CSB representative coming out. It could be a private agency. That dispatch works through a GPS system. So it's really going to go by who is checked into the system and who is the closest to that person geographically so that the response can happen quickly. The follow-up care for that service can go on for 72 hours. It is a very brief response and really just meant to try to link people quickly to what they may need. The next service is Community Crisis Stabilization. So this is an outpatient crisis service that can go from 7 to 14 days. It really focuses on, again, meeting individuals where they are. It is meant to be community-based. Most of these responses should occur out in the community. However, we know that sometimes the individuals we serve don't really have a steady place to meet. Maybe their home isn't really where they're feeling comfortable. It can be a chaotic situation for them. So clinically, maybe it's better for them to come into our office. Then we will make that accommodation so that they are getting what they need. Part of this is risk assessment is completed to make sure that they're appropriate for this level of care. There is also a safety plan that has to be completed. That is a requirement so that we know that they can remain in the community safely. At any given time during mobile crisis or CCS, if a clinician feels or one of our other staff feels that maybe the person is decompensating and might need a different level of care, then we can reassess to determine if maybe we should go with a higher level of care. So that follow-up care, again, can be 7 to 14 days, and it is focused on linking individuals either back to their existing resources or to new resources to stabilize whatever that crisis is. A lot of times we see individuals who come to us that don't have any counseling resources or psychiatry, and so we can start kind of being that bridge for them. One of the things about crisis is we're not set up to be the primary provider. We are here for when the crisis is occurring and when we're needed, but our goal is to link people to what they need ongoing so that they don't really need to rely on crisis as much, but we are here when they need us. And then our newest service is 23-hour crisis stabilization. So this occurs in our crisis center, and this service allows individuals to stay with us. They can do 23 hours, anytime up to that. We are not residential, so it cannot cross over that 24-hour threshold. We're not allowed to have beds because we're not a residential crisis stabilization. We have recliners and beanbags. During that, there is a clinical assessment. There is a nursing assessment to make sure that they're stable enough to stay with us, and there's a psychiatric evaluation that is completed in that time frame. At this time, the psychiatrist will sometimes prescribe a PRN medication that we have in stock if there's something that is an immediate need. However, they are not currently starting treatment, but in the next few weeks, we will be moving to that psychiatrist. If they choose to start medication management, they could go ahead and start the individual on a medication with the agreement that they would be given a follow-up appointment with a provider, most likely one of our psychiatrists, within a 2-week span. So it would just be like a 2-week prescription of the medication, and there would have to be that follow-up. So we do offer the service for adults and also children ages 10 and older. We initially started ages 14 because that really aligned with what the code had as far as kids volunteering for treatment, but it's not a licensure rule, so we were able to kind of adjust that some, and we have found that more kids come in that 10, 11, 12, 13 age range that really could benefit from the service. So we don't want that to be a barrier. We want to be able to keep kids out of the hospital and provide this service. So with crisis, the 23-hour crisis stabilization, it really gives us a longer time to provide an evaluation. A lot of times when we see individuals, we're doing an assessment, and it can be tricky to decide what the appropriate level of care is. And if they are, able to stay with us for a little longer, we can watch for signs of decompensation, or we can work on safety planning measures that would allow them to discharge home more safely. So these services for us in Danville, they all occur at our crisis center. So we are considered a crisis receiving center. So in this location, we are 24/7. We, much like the hospital, never close. Individuals can come to us anytime. We do operate under a no wrong door type of modality, in that if someone comes to us and maybe we're not the right place for them, we're going to help link them to the right place. I will say this is for mental health crisis. Sometimes there is a little confusion in that, okay, well, this person's homeless, they need to go to the crisis center. And yes, homelessness is a crisis. However, that's not really what we're trained and equipped to handle. So maybe they're homeless, but now they are suicidal. They're very depressed because of that. Then yes, they would be appropriate to come here. So out of this location, we do our emergency services assessments. We also come into the ER to do those. If an ECO is initiated there, or if the ERT has seen an individual and thinks that a TDO would be more appropriate, we come in and do those assessments. Maybe someone went to 4J voluntarily and then has changed their minds. We'll come over and do the TDO assessments there too. But most of our services are provided in this location. Mobile crisis, we are housed here, but they are out in the community more. Regional mobile crisis, same way. And then the community crisis stabilization, that also can start here, and 23-hour. We also have CTAC here. Our CTAC used to be in the emergency, like next to the emergency room, and that's where we have an off-duty officer who is able to take custody of ECOs and then allow that officer who brought them in to get back on the road, just to be a better use of resources. So that is also located in this building. So Piedmont, they have a crisis center as well, and theirs is located on Commonwealth Boulevard. It's also open 24/7. Theirs is a little different. It is, again, 24/7, but they have the emergency services. They have 23-hour. They, at this time, are not doing their own regional, own mobile crisis, but they do partner with us at times to have our regional team come out and provide that service if that is what is needed for the individual. And I don't think that they have community stabilization at this time. One of the things that changed with CSBs several years ago is that we became required to provide same-day access to services. So for Danville, an individual can come in and complete an intake for services that day. With being a CSB, we don't want income or insurance to be a barrier. So you don't have to have a specific insurance to come to us. If someone can come to us with very low income, they'll get a financial assessment. There's normally a fee reduction and just a lower fee to be able to provide that service. And those intakes occur Monday through Thursday, 8:30 to 3:30. With that, our services do have set criteria, so not everyone necessarily qualifies for one of the ongoing services that we offer, such as case management. Our counseling is more for substance use counseling as far as adults. A lot of kids will qualify for the services just because the criteria is a little more lenient for kids. But anyone can come in for that intake, and what we generally do is do some type of triage. And if it doesn't look like they're going to qualify for an active service, then a lot of times they'll go ahead and be informed of that ahead. And then they can choose if they want to go through the full intake or not. But that way they're not there for several hours just to be told that they need to go somewhere else. We do try to make that easier for them, and then we can provide community resources. And sometimes people come in for same day intakes and they end up being referred over to crisis. So, and then we assist with that too. Piedmont has a different same-day intake process, and their hours are different. So they do Monday through Thursday, 8 to 3, but then they also have hours on Friday, and they have it located in several locations for their different counties. In Danville, Pittsylvania County, all of ours is at the same time. I do know they do the financial assessment and things of that nature as well, and they would have the set criteria. But for more specific questions about that, I would encourage, reaching out to them. And of course, CSBs aren't the only places where there are services. So you have a lot of private agencies that provide different services, such as some will provide crisis services, some may have outpatient counseling or substance use counseling. There's really just so many in our area, but we do have a variety of services that are easily accessible to individuals in crisis because we are 24/7. And as I mentioned, income is not, we don't want it to ever be a barrier. With the expansion of all these services, we know they're working because our TDO rate several years ago was about 60%, and now our TDO rate is between 30 and 35% on average. So we know that the services are working, and there will be other services to come in the future, but this is where we are right now. And then as we do expand our services more, we will make sure that we are letting our community partners know what that looks like. Are there any questions?
Any questions for Ms. Pruitt?
I have one from a nursing standpoint. We often get asked by officers on the floor if a CTAC officer is available. How would we go about knowing if an officer was available?
Okay. Are you Danville or Martinsville?
Martinsville.
Okay. I would have to probably divert that question to Martinsville. So for us in Danville, we the policy that we came up with our community partners, so that would be with Danville PD, with Danville Sheriff's Office, and Pittsylvania County Sheriff's Office, is that for an individual to come to CTAC, they need to come to our crisis center at first. And what we were saying was the crisis center is where individuals should be brought for the crisis, that assessment, but it was kind of getting bypassed. And then, so the protocol that we put in place is that if they come here and the CTAC officer is available, but for us, we wouldn't send the CTAC officer over to the hospital where someone is not, where they never came through CTAC to transfer that custody to the CTAC officer. I would have them take that question back to their CSB, back to Piedmont, because the technically that CTAC would be through Piedmont. So I would divert that back to them, honestly, to see what their protocol would be.
Okay, thank you.
Other questions? Yeah, thanks. Other questions for our panel? Well, it's wonderful that we have. I'm sorry, go ahead.
Oh, sorry, Dr. Moore. This is Tori Shepard. I had a question for Ms. Huffman. I just wanted to make sure I could understand clearly. If we have no custody arrangement for a particular individual here, let's say they were on the TDO and expired, we're in the middle of trying to get an ECO, but the person has expressed harm, what is our obligations at that point? I just want to make sure I have that clear.
Okay. And presuming they don't have an advance directive that has authorized somebody to make that decision for them, right?
Yes, and I
Okay.
guess to be maybe take it a little bit further, and this individual wishes to leave the building.
So my first advice would be with an ECO in the 8-hour, sometimes those do expire because it's so quick, but really the TDO, the 72-hour, should not expire without us. The statute says that commitment hearing has to happen within that 72 hours. So once you get to the TDO phase, you really should not ever be in that situation, because we should have the stopgap so the commitment hearing happens before that 72 hours expires. If by some chance that does not get done and the order expires, we can't hold somebody absent an order or that advance directive. So if they are pushing to leave, you'd have to let them leave and call law enforcement literally as they're leaving and ask law enforcement to pick them up and bring them back in because they have expressed immediate intent to harm themselves or others. But again, really only that ECO should be our risk of it expiring. The TDO should never put us in that situation.
Okay, thank you.
Sure.
Other questions?
Can I speak to that point?
Sure.
I think where it's a little different here. Of course, that's the law with it, but unfortunately, the system is not working the way that it is designed to work right now. And so, we used to never see there be hearings in emergency rooms, and now we have commitment hearings in emergency rooms 2 and 3 times a week. It's not how it's supposed to happen, but there is a backup in the system. And so I think for us, what I see in Danville is the bigger issue is after that commitment hearing, then the law enforcement does come off of sitting with that patient because legally that's what's supposed to happen. And so that's where we have bigger issues on our end, I think, with individuals eloping because there's really nothing there to hold them. So I know that in Danville, we have a process where the hospital would, there's a paper warrant that they can get, which allows law enforcement to then bring them back in. However, that warrant allows them to deliver them to the hospital, but not necessarily stay with them. So even once they're delivered, there's still that risk that the person can try to elope again. So we know it's super frustrating. And I will say that if we know that someone is a flight risk and is, really going to be at risk of harm to themselves or others, then we try to work with DBHDS's central office to push that admit happening to get them moved into a state facility quicker. Sometimes we're successful with that and sometimes we're not, but it's just hopefully this issue resolves itself soon because it's not how it's supposed to be.
Other questions? Okay, well, I appreciate this very much for the 3 speakers, and particularly them staying on the call with us throughout the program. I do think it's reassuring that we have these mental health facilities available. As you read in the lay press now, there's so much or such a great need for mental health support and help to folks that, while we still have problems to work out the systems, they are a lot of resources here in Danville, Pennsylvania County, Martinsville, Henry County. So thanks to each of our 3 speakers. Thanks for everyone being on the call this evening. I hope you'll be able to come back on November 7th. We'll talk about how to promote long-term adherence for patients with asymptomatic conditions, meaning high blood pressure, type 2 diabetes, hyperlipidemia. And if you're a nurse practitioner, don't forget about the Saturday, November 9th morning sessions that are available for CE credit at that time. So that being said, thanks for being on the call. It was an excellent program. I remind the residents, please be careful out there and whenever we meet, and we hope to see you back in the next program real soon. Take care. Good night. Bye-bye.
Thank you all.
Thank you. Bye-bye.